patients, but they've backtracked. They say, no, only 5 years after your replacement. Dr. Athavaraham and Dr. Liu feel very strongly about lifelong. So it's one dose an hour before you see the dentist every 6 months. Bactroban. Bactroban is that crazy ointment that I asked you to pick up. There's a prescription in your packet that you need to go to the pharmacy, pick it up. It's an ointment that kind of prohibits infection to go to the rest of your body. Our nose is kind of the functioning of a filter, so when we breathe things in, some of the bacteria gets caught in our nose hairs, and so that antibiotic ointment will kind of take away that risk. So that's the Bactroban. You'll use that ointment on a Q-tip, put it in your nose twice a day for 5 days prior to surgery. Another arsenal that we have in our arsenal are the surgical wipes. These surgical wipes have been developed by the University of Chicago infectious disease people. There are 3 in a pack. The night before surgery, you'll take 2 of them, and you'll take a shower and wipe your whole body down with these 2. Not your face or genitals. Have someone in your family help you with your back. Should be an all-body thing. The morning of surgery, you take the 3rd one, and you'll do just the knee or the hip that doctor's doing surgery on. Now, Dr. Athavaraham has a different procedure with these. He would like his patients to use these for 5 days. So if you're a Dr. Athavaraham patient, it's 5 days. If you're a Dr. Liu patient, it's the night before and the morning of. And if you did not receive these yet, just come and see me after class, and I can give you one of these. So like I said, the lifelong caution about dental care, bacteria infections, and wound care. Now, if you would have a cold or a sore throat or an earache or even a toothache, you need to see your primary care doctor. If you have a fever, that may be a bacterial infection. And this is a lifelong commitment. Always have that in the back of your head. Oh, I had a really high fever and I had an earache. We always worry about that bacteria going to the knee replacement or the hip replacement. Because what happens is when we have bacteria in our body sends blood and washes it out and cleans it out. But when you have metal here, it's a lot harder for the blood to get underneath here. And if some of the bacteria gets harbored underneath here, it has a potential to become infected. So if you would have an infection, call your primary care. Tell them I had a knee replacement and I have a fever, I have a really sore throat. And if you have any concerns, you call me or Jennifer. Once again, if you're concerned, we're concerned. Please call. Now, if you would have an infection, say, 5 years from now, and that hip or that knee were doing just wonderful, and all of a sudden after the infection you've had a lot of pain, it's stiff, you have a little fever that keeps on, you should call us right away because there is a small window of opportunity that we can wash out this area really well before we have to have something more final to take all this out. So once again, if you're concerned, give the office a call. So another risk for surgery are blood clots. And there are 2 blood clots that we're concerned with. One is a deep vein thrombosis, and the other one is a pulmonary embolism. The pulmonary embolism is a blood clot in your lung, and that is an emergent situation. For the first 3 weeks after surgery, if you would have any problem with deep breathing, you're coughing up blood, you just can't take a deep breath, you need to go to your local emergency room immediately. Don't call our office, just go to a local emergency room. There's a very simple test that they can take to see if you had a blood clot in your lung. Tell them you recently had some major surgery and you're having a hard time breathing. Now, the surgery you're having is below your belly, so you're going to have swelling in your legs. It's all part of the surgical procedure. You get some swelling. So you need to make sure that you elevate your legs as many hours of the day as you can. And when I talk about elevation of your legs, I mean higher than the level of your heart. So you need to draw an imaginary line from your heart to your leg, and your leg has to be higher than that. So if you're sitting in a chair and you have this wonderful, nice, soft hassock in front of you, I can guarantee it's not high enough. I always tell Dr. Lou that I think it'd be wonderful as a thank you gift. All our patients receive a nice lazy boy chair, you know, because the back goes back and the legs go nice and high. That's how high we need to have your legs, higher than the level of your heart. And you really can't do that enough during the day. If you're sitting in a chair visiting, watching TV, reading, make sure those legs are elevated. Now, if you call me and say, I cannot get the swelling out of my legs, and you promise me that you've been very diligent about elevating, then I'll have you come in because we may suspect a deep vein thrombosis or a DVT. And once again, that's a very simple test to determine whether there is a blood clot there or not. So if you take nothing else from my class right now, higher than your heart is the elevation. So Dr. Lou and Dr. Athavaraham, once again, take blood clots very seriously. So what do we do about that? First of all, early moving, walking around. If you are having your surgery early in the day, you will be walking around in recovery already. Because if you walk, you can feel that your muscles and your legs are the blood is being pushed through. So early walking, you get those legs moving. Another thing that we do are ankle pumps. And you can do these in the hospital, you can do these at home. And what you do, you take your ankle and you pump it and you rotate it. Because once you do that, you can feel the muscles pushing that blood through your lower leg. Elevate your leg. And how high are you going to elevate your leg? Above your heart. Thank you. And then we also have TED hose, which are those white tight hose that we'll put on you. If there's swelling in your leg, doctor will actually order some that you'll take home. You don't have to wear them at night, but you do need to have them on during the day. But remember, they're very difficult to put on by yourself. So this is where your care partner will come in, take them off at night before you go to bed, and they'll help you put them on during the day. So the white hose. And then there are two medications that we use, Coumadin and Xarelto. Dr. Lou uses Coumadin. It's a blood thinner that you'll be taking for 3 weeks, and you need to have blood draws twice a week to make sure the dosage is correct. So you'll be on that for 3 weeks. Dr. Athavaraham uses a medication called Xarelto. That's also a blood thinner, but it does not require blood draws. But those you'll be on that for 3 weeks also. And the last thing I want to talk about is for both the hip and knee replacement surgery patients is a risk of death. It's major surgery, but if you have gone to your anesthetic appointment, you know already that your primary care has to say okay to the surgery. Are you being treated for diabetes? Your diabetic doctor has to say okay. If you see somebody for your heart, they have to okay it. And then once all your outside primary care doctors have said okay, then you'll see the anesthesia people and they'll put everything together, and they once again will have a good physical, make sure you're in optimal health before Dr. Lou or Dr. Athavaraham will do the surgery. So all your doctors are the gatekeepers before a doctor will do the surgery. I'm just going to talk a little bit about 3 risks for people who are having hip replacements. Number 1, limb length discrepancy, which is a big way to say you feel uneven. Your new hip might feel a little bit longer, and that is something that will go away. Doctor does do all kinds of measurements to make sure everything looks level, and he will look at it, and usually at 3 months, if you're still having that feeling of being uneven, then he'll probably put a little lift in your shoe. But that's not something we're concerned about right away. Hip dislocation. There is potential for hips to be dislocated if you do the wrong thing, you make the wrong move. So your therapist will go over and over and over. This is what you can do, this is what you can't do. And the last thing is nerve pain. The nerve pain is for the hip and knee people because there's a lot of things going on. There's a nerve that could be kind of jostled around a little bit, and it would just be painful for a while. and that only happens to 1%, and it usually is temporary. Now we're going to talk about the parts of the prosthetic knee. There are 4 parts. This is the tibial component, the femoral component. This is shaved. The tibia is shaved and made this to fit right on here. This is the tibial component. Your bones are like chicken bones, so this goes right down the middle. And this is the plastic, or this is what takes the place of your meniscus or cartilage. And it fits right on like that. And then your kneecap, doctor will put a little backing on the kneecap just so it slides over here really well. So 4 parts to a knee replacement. There are also 4 parts to a hip replacement. Once again, your bones are like chicken bones, so this slides right down your femur. This is the head of the femur, and this is the plastic that fits right into the shell of the pelvis that your hip replacement rotates on. Now, when I talk to people about hip and knee replacement, they're like, well, you don't really take anything out of a knee. We don't. We kind of shave it and just form it, make it fit nice. But contrary to that, in a hip replacement, we do actually take something out. Doctor has to actually take the head of the femur off. This is cut away because this is also bad for the cartilage, and it's bad for pain because it no longer is bearing the weight that you need to have. So this is cut away, and this is put on there. So how does doctor know which knee replacement or hip replacement he wants to use? Because there are as many prosthetic knee and hip replacements as brands of cars. There's Biomet, Johnson & Johnson, DePuy, Smith & Nephew, Stryker, Zimmer. And if you watch TV, you'll find out a lot of those have been recalled, and you're always worried about that. But I want you to be assured Dr. Lou and Dr. Athavaraham have never used one that's been recalled. So how do they decide? Well, you had all kinds of x-rays taken before your surgery, and doctor does measurements, and he looks at the bone structure to see which one works best for you. Dr. Athavaraham prefers the Stryker knee method. The Zimmer knee method. Dr. Lou uses the Stryker knee hip and knee replacement. And why do they decide that? Because usually it's something they've trained with, they like the instrumentation, they're used to it, they like the way it feels. But you need to know that if they do those measurements and they feel like something else will fit you better, they will go to a different product. This is not something that's on the shelf and they just pull it off the shelf to fit it into you. It's measured, it's looked at, and it's very conformed to your body.